So today I have the pleasure of speaking to what my colleague, Dr. Pat Agnew, has dubbed the Elon Musk of podiatric diabetic research. And it's a real honor to have him here today. And he's going to live up to that billing, I'm sure. And I'm not going to go into all his accolades. He's got a gazillion. But the first thing I wanted to start with and welcome Dave is beautiful background of your facility. We've had a crazy year. I just got Barry Block's issue of Podiatry Management, and they were talking in one of the lead articles about the comorbidities with diabetes and hypertension with COVID. What have you seen on the front lines that you think would have some of the biggest impact to prevent death and some of the comorbidity things that we see down the line from what you've seen that maybe people aren't aware of? I know that's a very broad question, but fire away. And
yeah. Well, first of all, Ben, man, it's great to see you. And from this side of the U.S., happy pre-Turkey Day, man. It's great.
Me too.
Really, it's great to see you. I hope you're doing well. You look great, man. God dang. But Elon Musk and podiatry, that's pretty great. I have a Tesla, and I do have some solar city panels, so some Elon Musk solar panels, and I have friends that work right across over here at SpaceX. So I guess from the toe doctor standpoint, maybe I'm 2/3 of the way there. But anyway, vis-a-vis COVID. I mean, my God, we're, speaking via Zoom. Everyone's all Zoomed out or Teamsed out or meted out. And after all this time, we're all so fatigued from this virtual world peri-apocalyptically. I had a conversation maybe in late February with Will Lee, who's a great guy, someone you ought to interview. He's a longtime friend of mine. He's the head of the Angiogenesis Foundation. And Will had a paper, I think it was in the summer, on evaluating some lung biopsies from folks who had passed away from COVID. But before that, he was talking about some findings that he was having with me. We had this 2 or 3 hour conversation that just went on, and it was not boring at all. It was quite the opposite. And, one thing is fascinating. He said, look, this is not a pulmonary disease. COVID is a vascular disease. And it looks like he was right. I mean, this may have pulmonary components to it, but this does definitely seem to affect the endothelium and the microvasculature in a way that is profoundly deleterious for some folks that are particularly sensitive to it. This is why, if you're a foot doctor, one of the first things that people were seeing were these so-called COVID toes. Those are little microembolic phenomena and little microvasculitides, all the way to those sorts of lesions and other end stage kind of end vascular organs. And this is happening very likely in the central nervous system. It's happening in a bunch of other areas around the body. But it's a fascinating sort of thing to think about. And most recently, in a couple of papers, one from Will Lee's group and one from others, it looks like this whole vascular concept is really taking steam. In fact, last week, there was a wonderful article quoting Will in NPR, on NPR. I think it was in Morning Edition. You ought to look it up. I think we put it on our blog. And I think it'll give you a broad-based kind of idea about the whole enchilada.
Would it be fair to say then, for the non-doc folks that are watching this on YouTube, that the vector is respiratory droplets, but that the pathogenesis, once it gets inside the body, is more attracted to the endothelium? The surface.
Yeah, it looks that way. It looks like that's at least a significant part of it that's been largely, if it hasn't been ignored, it's been downplayed, in that people are talking about this like the flu, and it's not like the flu. I mean, sure, respiratory droplets, I mean, it being passed from person to person like another communicable disease, but the some of the end stage end organ kind of complications are decidedly different. I think we could say that.
One last thing, how much, and you know, I lost my dad this year, had a stroke, not thought to be COVID, but I think that, and I was talking to, we had Gary Hall Jr. a couple weeks ago.
Oh,
And we were,
that's great.
yeah,
What a
he's
great
an
guy.
awesome guest. We were talking about the change in habitus. So it's kind of a two-pronged question to you. Do you think that, I'm not saying way early on in February when the testing wasn't accurate, but like later on, how much, from what you're reading in scientific reports, could people be COVID even with the PCR tests that might be missed as contributing to, you know, just undiagnosed COVID? Certainly, I think papers are going to start coming out about changes in habitus, not seeing the foot doctor as much, not seeing the cardiologist as much, that then lead to, you know, things spindling downward.
Yeah, Ben. Well,
That's
that's a
kind
great.
of two levels of the question. How
Well,
much
I
COVID
think
do you
it's a
think
great
is
question.
being
I
missed?
think
And then,
I think at the end of the day, you know, I guess post pandemic, we hopefully not post apocalyptic. We're going to be able to look at some of these data and see what the actual additional burden. When we look at death rates, I think we'll be able to see what the overall kind of additional burden of the disease was. And I think that's probably going to be able to give us a little bit more idea about maybe some of the folks that might have been undiagnosed. Does that make sense? And
yeah,
that's not only in the United States. That's going to be all over the world. And I think there are going to be some countries that maybe tested more, that maybe where that you know, additional burden has already been captured. And I think in other countries where maybe there hasn't been as much testing, where maybe the we're going to find, you know, there's a significant burden of disease here.
yeah. Now, on a brighter note, and one that you've gotten me very interested in with that organ replacement parts lecture that you spoke about. Tell me a little bit, now that we've had another year or two since we've really talked about this topic, about where regenerative medicine is with diabetes and the vascular tissue in terms of where you see things going, and then how close are we to pancreatic islet cell things that are going to help with diabetes from that aspect, from organs. Give me, and you're at a state-of-the-art facility, may not be obviously as disseminated to, you know, community hospitals, but where are we in that continuum?
Yeah, happy to talk about it. I mean, there's so much to talk about, but we could first talk about, look, we could take this wherever you want, but let's first talk about stuff that could potentially, you know, happen right now. And that is just with kind of reconstructive surgery. I think that what we're seeing in folks with significant tissue loss, you know, like for instance, with wounds and with diabetes, it used to be that patients would just get an amputation. I think maybe up to about a generation ago, that was really, really common. It still is really common in a lot of places. But what we subsequently saw was that there were other maybe technologies that help patients maybe heal a bit more readily, and that was something like, you know, negative pressure wound therapy, or the VAC. In fact, when you think about it, the VAC, for physicians and surgeons that are watching this, that device transformed how we heal these wounds, you know. But what it also did, unfortunately, was it made plastic and reconstructive surgery, or basically flaps and grafts, much less common in this population. And so those were done a lot less frequently. But taking tissue from one place and putting it in another has really dropped off over the last maybe 20, 25 years because of negative pressure wound therapy. What we're starting to see now at our center, and it's being led by Keaton, one of my really good friends, Keaton Patel, who's a gifted plastic surgeon, along with Joe Carey and others, are using various types of flaps, and not just the classical ALT, anterior lateral thigh flaps, but what are called skip flaps, or superficial circumflex iliac pedicle flaps. And those flaps, they're super thin. And a lot of this was pioneered by not only by Koshima, but by my other friend JP Hong in Seoul. Can be taken and put down there into these wounds and tied in using so-called super micro surgery, basically a microscope, and like sometimes 10-0, crazy 10-0 suture. That doesn't require, because it's so thin, it doesn't require a lot of blood flow to keep that piece of tissue alive. And that's almost like replacing an entire, we call it a whole angiosome. You're just replacing it. You're just going to take it from one place and put it in another. So that's one thing that with an appropriate skill set and a member of your team that has that skill set, whether he or she's taught that or develops it, could happen now, and is very exciting. So I think we're going to start to see some of those kind of come back, like the free flap is sort of back in some ways for some of these patients. That's number one. Number two, there are some really exciting developments. I'll give you an example. I'm a principal investigator on a nationwide study of spread-on skin, led by a company called Polarity. This is a multi-center study in the United States, but it's pretty cool. You take a little piece of skin from the thigh or wherever you want to take it, leg, you send it off to the lab. It then gets processed and sent back to you just under a couple of days. Or you could have this done actually in your own kind of unit if you have the actual device to do that too, but it's sent off to a central area, generally speaking, for processing. Comes back maybe a day and a half or so, and then you take it, and it's like a little slurry, and you can then take and then you can literally just spray this on. Excuse me, you can spread this on, just like spreading on, butter onto toast, and it actually now is developing not just split thickness skin components, but certain aspects of full thickness skin components, which is fascinating. The early data that we reported in a planned analysis a few months ago were better than we thought. Actually, I was not at all expecting to see any significant difference in the initial analysis, but there appears to be one. And we'll see how that comes out. We should be getting data into 2021. And I think that'll be something that we may all be using a bit more frequently. In addition to that, we're studying some really cool adipose-derived allogenic stem cells from Korea. Those are delivered and then applied to the wound. The early data there also look interesting, really, really quite promising. A third sort of thing in that, if you will, regenerative medicine space, although there are so many others, but I'll bring one other up that I'm the principal investigator on, is this fascinating study with technology from Japan, and it's from a company called Angie's, and that is that's real gene therapy, and this is what appears to be the first gene therapy study done really for tissue repair and wound healing, where we are taking HGF, so hepatocyte growth factor, and it's in a plasmid, and we're injecting it just into and we're injecting it into the musculature around a blood vessel blockage on the legs and delivering it down, and then that is improving blood flow, hopefully to heal neuroischemic wounds in patients with diabetes. That is a study that's going on right now around the country at, I think, 15 or 17 sites, on which I'm the national PI, along with Mike Conti from UCSF, of one of my old friends and a world-class vascular surgeon. And I think that may very well be a thing. So stay tuned right there as well. So those are 3 things. There's so many others as well.
That's great stuff, Dave. What about let's say, the more mundane sort of dehiscent situations where it might not even be a diabetic, but somebody who has rheumatoid arthritis? A physician has done a bunionectomy. You get that slogging dehiscence that's going on. You're waiting for approval for one of the organogenesis products. It's got to be a certain amount of time, and you're sharpening, doing your sharp debridement, trying to get non-sessent cells and so forth.
Yeah.
Is it your cardinal rule that you generally, unless you're, it's a bigger situation where you have to move a flap, where you've shied away from like delayed primary closure if it's really close? Or do you still do that in the clinic?
We still do that a lot. If we can close something, yeah, we want to try, depending on the level of vascularity in there. For patients who have significant ischemia, we've actually found that we actually, and I know it sounds a bit paradoxical, but in fact, for people that are profoundly ischemic, we have found actually that leaving some of these wounds open and then actually backing them sometimes with biologics and then skin grafting them is sometimes a bit better in terms of outcomes. We have fewer wound complications when we do that, but that's very different than what you're asking. You're asking about things like maybe a dehisced wound, if we can mobilize it and close it. If we have an option to do that, for sure we will in most cases. But you really hit on a good point, Ben Pearl, because it's that, when these wounds become chronic, it's exactly like a slow running wound is a lot like a slow running computer. Like if you're upset at your computer, you're saying, God dang, this thing's running so slowly. What's going on? I don't have any tabs open or whatever. You open up your activity monitor if you're so inclined, and you look and you see all this stuff running in the background, right? All these things you don't even know what they are running in the background, all these programs. And it's the same thing in a chronic wound. In a chronic wound, if we were to biopsy it or if we were to evaluate it just objectively, we would see that there are so many things running in the background, so many of these sort of low-grade inflammatory cytokines and chemokines that are creating this kind of gamish of bad, if you will. If gamish is a medical word, then that's what we're seeing. And it's just causing anything that we put in the wound, in many cases, especially if it's a protein, just to be chewed up in a few seconds, right? And we wonder why some of these products that we squirt or slap or staple in a wound, we come back the next week and the patient looks about the same. If we haven't really done a good job of preparing the wound, then none of those things are going to be very helpful. So what do we do? What do you do to a slow running computer or to a slow healing wound? It's kind of the same thing in a way. What do we do with the computer? We hit Control, Alt, Delete, right? Same thing with a slow healing wound. Control, Alt, Delete. These wounds very often need a very good quality surgical reset. And we do not do that enough. And when we do that, and sometimes we can do it really well in the clinic, but sometimes it pays to go to the operating room. An example, I took 2 cases to the operating room yesterday that I could have easily done, and I often would do in the clinic, but I took those 2 particular ones in there because I just wanted to do a really good quality debridement for these otherwise very sick, very complicated patients, and I really wanted to hit reset so I can get those wounds to reboot. And as the wound is rebooting, I can apply something, or I can into that wound, and maybe we have a little bit of time to apply that thing in the wound, and maybe it's going to run a little better, just like any program that we might launch on our computer after we reboot might run a little faster, a little bit more with a little bit more security that it's going to actually not just get bogged down.
That wound trajectory that people like to talk about, getting back on.
Yeah, they are, Ben.
Yeah. What about hyperbaric? Do you think it's overutilized in terms of, at my institution, for instance, I'm at Virginia Hospital Center.
Yeah.
They built one, and it seems like that becomes this sort of the algorithm.
Yeah.
And that's all well and good. I'm just wondering, from somebody that's seen kind of the full gamut.
Yeah.
Is that something that becomes a sort of a supporting thing because of the fact that it's built, or do you think that they should be as busy? And I hopefully you're not on the board of a hyperbaric chamber where you have a conflict of interest.
No, I'm not.
Appraisal.
Not at all.
Diving for dollars.
Yeah. Well,
No, I mean, I know they can really be beneficial. I'm just wondering, in from what you see in perspective, what is your, and you're the person to, because you're all over the country and all over the world. So what's your kind of thought process on utilization?
Well, look, I was, in the first kind of place where I kind of got my start as a fellow and then as a junior attending, a quarter century ago, was in one of the birthplaces, if not the birthplace, of hyperbaric oxygen. That's San Antonio. That's where the kind of undersea hyperbaric society kind of started at Methodist Hospital, right across the street from UT San Antonio. And I was inculcated in this very, very early on, having come from a surgical program where we never really saw hyperbaric, but it became something from which we had a lot of experience, and we were involved in a lot of the research with that. I think there are data to support hyperbaric that has some benefit. I think there are positive and negative data for hyperbaric. There are also some interesting data that suggests that hyperbaric may have an effect that may be life-sustaining in some cases, believe it or not, and in some of the randomized controlled trials. That has to be explored a little bit further. However, I believe that it has gotten a bad name and a bad rap because it's been overutilized, and it's been used more like an ATM, in my opinion, than like a medical treatment. And entire companies have been built around it. But there have been companies that have hyperbaric centers in them, in wound centers, that are not sort of focused solely on that. And I think many of the companies that had been in the past have seen that it's only one part of the whole treatment. And I think most of them would agree on that now. So I think that's kind of where it's settled. But let me tell you something. There is, and I would have never talked about this 5 years ago for sure. I would have just pinched myself, or not pinched myself, I slapped myself. Topical, I'm laughing when I say this, topical oxygen sounds like quackery, but it is not.
Talking about it. Yeah,
there are
issue again. Go ahead.
Oh yeah, is it in there? Well,
yeah, yep.
Yeah. So there are data that suggests that the skin does respire. Chandon Sen, he used to be at OSU, the Ohio State. Now he's at Indiana. He's I think the VP for research at Indiana. Oh, yeah. Are you really? Good for you, Bloomington. Man. Look at you, you Hoosier. Yeah, it's not IUPUI. He's at Indiana, so he in Bloomington. A really good guy. He's a basic scientist. He and his much better half have been looking at this for 20 years. But still, I had said repeatedly that unless your legs have gills on them, I'm not sure how these topical devices are going to work unless they've evolved some a sort of fish-like sort of respiration mechanism. But look, I was wrong for sure, because I don't say for sure very often, but in this case, there are now 3 or 4 separate, at least, randomized controlled trials. There are emerging meta-analyses now that have been well controlled that show with sham controls that putting topical oxygen devices on these patients, appropriate ones, not, that there's a real signal. There is a real physiologic signal. And I think it's only a matter of time now before these are approved for use and reimbursed and whatnot. But they just have to be used appropriately and not overused. But these are going to be compared to hyperbaric, and it's not hyperbaric. Obviously, it's more like a wound chamber, if you will. It's sort of just creating a sort of a system for healing, almost a greenhouse, if you will, in the most positive sense for wound healing, not for growing bacteria, but for growing wounds and healing them. And I think that this is an exciting area, frankly. And the other cool thing is it doesn't seem to be, it's not really competitive with any of these biologics or anything like that. It maybe could be synergistic with some of them. Yeah. So stay tuned for that. Because I really think that these data are already emerging, and I'm happy to be wrong about that, because gosh darn it, it's something that could be done relatively easily and inexpensively, and it could make sense.
Well, David, it takes a man comfortable in his own skin to admit that science bore out something that he didn't think was going to happen.
Oh yeah, for sure, man. I'm
you're a straight shooter. I like that.
This is great, though. I mean, it's great to see these data kind of emerge, and what can you do? I didn't tell you, I was an investigator. I was an author, a senior investigator on one of those 3 or 4 studies, and all these studies are with competitive products. But the big idea is that they all seem to be, they're moving in one direction, and it's great when you see that in an area, and especially in this area.
Well, I want to ask you and move on to neuropathy. That's a huge area also, and I was talking to before we started, recording this about some of the supplements. Obviously, nutraceuticals, huge industry. I have companies that are knocking on my doors, trying to get me to get patients to get $300 tests, above and beyond B1, B12, and the basics. But from what you understand, and one of the big things that I use in my practice, and I read a Mayo Clinic article on it and started using alpha-lipoic acid. Why is it that we in podiatry seem to be more utilizing these supplements? You talk to neurologists, they're still using, tricyclic antidepressants for neuropathy and some of the other, and maybe I don't keep up with the neurology meetings like you would, but and maybe now they're moving on to other things that I'm not aware of. But what seems to be the divide there, where you've got people that, you've got these, what seem to be some reasonable articles on it, depending on the nutraceutical or the thing, that the factor we're talking about. But what's your overall take? And maybe
we're all of us
the other stuff
in our different specialties, in surgery and medicine, in nursing and therapy and whatnot. We all have our own cultures, and if you will, and I think different specialties often have different affects, and I think that podiatric surgeons and podiatric physicians in general have been often a little more will often be early adopters, or there are certain segment that are a bit more early adopters. But I've found, look, there's plenty of neurologists that I know that are early adopters as well. But looking at peripheral neuropathy within the larger context of neuropathy or of neurology as a specialty, it's just a small portion of the rest of a massive specialty and a really rich specialty in neurology. So focus on it is not it's, it's not a prime focus for most neurologists. Although I must tell you, I have some really good friends that are world-class neurologists that have an interest in it. There are also endocrinologists that similarly have developed interests in it. In fact, I was just talking to two colleagues and friends, Radhika Papbasui and Ava Feldman from Big Blue at not IU, but University of Michigan. Same, there you go, Big 12. But they in Ann Arbor have really been pushing a lot of this stuff as well.
What do you like to use in your clinic in terms of diabetic neuropathy? What's your kind of primary and secondary?
Are you talking now about painful
diabetic neuropathy,
or are you talking okay, so let's talk. Well, there's a lot going on now, actually, believe it or not. And there hadn't been a lot for a long time. There has been a bunch of failures, actually, for the longest time. So a couple of things we could talk about. First, just let's talk about the natural history of neuropathy. So if we're talking about, if you look at neuropathy and you look at it like a timeline, you know that painful neuropathy and painless neuropathy or loss of protective sensation are two kind of different things. And generally speaking, people develop aspects of painful neuropathy sooner, and it kind of peaks over time and then kind of tails out over the long period of time with diabetes. Then at painless neuropathy, which is kind of a slope upward in terms of prevalence, to where if you've lived 10, 15, 20 years with diabetes, there's a likelihood that you'll have painless neuropathy, whereas the painful may have peaked a little bit sooner. And then hopefully reduces, but not in everyone. And then there's a segment that have both. They have painful and painless neuropathy, which is terrible, just is terrible. That's the old John Ward, painful, painless foot. But if we're looking at things that alter the natural history of neuropathy, you had mentioned already some of these there are data to suggest that certain supplementation, like you mentioned, some of the B supplementation may modify the natural history of loss of protective sensation. There are data that suggest that this may also be true for aspects of alpha lipoic acid. It also may be true by keeping yourself in better glucose control and better, believe it or not, lipid control may also have a net protective effect on the peripheral limb. So these are things that we like to optimize in our patients. We like to go with what we call best medical therapy. And this is stuff that we have not done well, just in general in medicine and surgery, but especially in what we're doing. So we have to just focus and make sure that our patients on that statin, that they are optimized in terms of the glucose control as well. Then for patients that have neuropathy, there's, people have been getting various types of antidepressants, all the way up, to anticonvulsants, and all the way up to, opioids that just gork them out. And the overall kind of sort of side effect picture to risk benefit picture has not been great with these products. And I think we can all agree on that. If we look at the data for pain relief, it has not been great for painful diabetic neuropathy. So that leaves modalities now. And, one thing that just came out is I'm sure you're familiar with capsaicin. It's been around forever, right?
Sure.
Probably one of the first things that you ever prescribed. Well, capsaicin is now available.
Peppers, as far as I understand, if you don't want to go out and purchase it.
That's what you get, right? So, but capsaicin is now available as an 8% patch. Became available, but that has to be applied, probably under supervision, with the patient. But that is a thing now, and there are some data that suggests that there's some benefit in mitigating pain in some of those patients, and maybe reducing the need for other things like some of the other orals. In addition to that, electrical stimulation has been around for quite a long time, and there's been actually quite a lot of data to support electrical stim, and we place electrical stim all the time with our physical therapists in our clinic on patients. But more recently, very recently, and this is very exciting, I think that we may be working with our colleagues in interventional and neurosurgery on this. In fact, I just got off a call with one of my buddies here at Rancho, Charles Liu, who's my brother from another mother. And Charles and I work together on a bunch of things. I'm just laughing because he's kind of a goofball, but we are really doing so many different things together. But Charles and I are going to be working on probably expanding things with another guy, Darren Lee, on expanding our offerings for non-pharmacologic pain relief, especially for painful diabetic neuropathy. One of the things that may be promising is, believe it or not, implantable nerve stim for spinal stem.
Sure.
Specifically, not just low frequency stem, which has been around for 50 years, but what's called high frequency, or so-called HF10, 10 kilohertz. There's one company that makes a device that is implantable and controllable externally. And that device has had initially, at the American Diabetes Association, the data were presented, and I've just forgotten her name. Gosh darn it, she's a neurosurgeon at University of Arkansas, presented some really intriguing, elegant data in a randomized control trial showing a really significant reduction in pain with this high frequency nerve stim. So I think we might be collectively working together with our buddies in neurosurgery especially to start doing some of this a little bit more than we are now. That could be a thing in the not too distant future. And there are also, and I have dabbled in this a little bit, peripheral nerve stimulation and peripheral nerve implants. We have had a little bit of experience with this over the last several years with different devices, and my experience has been pretty good there too, but not like what we've seen with the data for the kind of central spinal stem.
One other thing that you might want to take a look at, if you haven't already, and I'm sure you've looked somewhat at this because it was a rage for a while, is that topical CBD is being looked at because there's a lot of heavy density of CB1 and CB2 receptors in the skin.
Yeah.
And that might be perhaps,
it's
at least for
well, there you are.
pain.
And I'll tell you what, man. Yes. And it's something that, yes, I think it's something that could be tested pretty darn well. Ultimately, I don't know if it ever will by industry, but it may be the kind of thing that we could get federal funding for eventually, because it would lend itself really well to a randomized controlled trial. That stands to reason, and it certainly could be something that we could entertain. And God knows here in LA, boy, if it's not a coffee shop or like a fancy pet store, it's a pot or CBD shop.
Sure.
In all of our streets, including my street on Ventura Boulevard. God, it's crazy. Every other shop.
I was looking at one of these health things on the Today Show, and they were talking about the stress of this past year and the importance of meditating and doing all these things. And this is going a little bit Eastern medicine, but one thing that was raised that I didn't realize that they've actually now been able to monitor this, but our telomeres in our at the DNA level actually change with significant stress, the aging and degenerative process, which is at the root cause of course of all the things happening in the basement membranes and neurologic function and so forth.
Yeah.
How have you managed in your, and we're getting to the finish line with 4 minutes left, and I know you got another call coming up, but how have you managed in your own life to mitigate stress, and how do you have any creative ways you've managed to do it with your patients? So again, a twofold question on managing.
Yeah.
So important on the process of disease and your favorite word, chronic inflammation?
Well, my dad passed away about 20 years ago. He was a foot doctor and smartest guy I ever knew. And by the way, my oldest, is going to be a third generation foot doctor. The middle one is headed, the middle one's headed to Greenland to do very soon now, to do a Fulbright, and the little one, who knows, she's probably going to work for the CIA or something. She's taking Russian at Georgetown. She's already been to the Russian embassy a couple of times. I'm sure they have a file on her. Are you listening? But our oldest is probably going to follow in this thing. But when I was little, my dad, I'd sometimes walk in the room early in the morning to talk to my dad. And my dad was like, just, sitting there just in the chair, just closed, his eyes closed. And this is just this big kind of hulking guy, and from New York, that was like, he was an alpha dude, and kind of very imposing to a lot of guys. And he meditated. And I thought to myself, what? This seems so touchy-feely. What the heck is he doing? And I just sort of let it go. And I think they were doing back in the 70s and 80s when I'm talking about, that was like TM, Transcendental Meditation. But God knows, for the last 5 or 6 years, I use an app, for like 15 minutes, I try to find 15 minutes a day wherever I am, I'm standing. And actually, I found that it does kind of help me check myself a little bit, from time to time, just to it sort of levels you out if you're in terms of stuff. I think it has. I actually, to be frank, hadn't really noticed much of an effect on my my overall affect, but my wife, I guess, my kids have, I guess. Maybe a little less hyper.
Let me just say you've delivered as promised. I can talk to you for a minute after this recording ends. But the other thing, exercise, and I'm sure you're fitting that into. You look fit, and I know you have another call to Australia today as well.
I do, yeah. I'm talking to one of my buddies down in Australia and one of my buddies here, Joe Mills. I think that we're doing a 3-way kind of conference on kind of the toe and flow. So it's and that should be great as well. We won't be talking about all kinds of fancy stuff like this.
What I want to do is we'll get probably streamed at any minute, but thank you so much for participating with this. And any parting thoughts about things coming down the road that we should be attuned to, either that you're doing or?
Yeah, sure. There's so many things, but man, I tell you, I'm so excited about remote patient monitoring. It's been stuff we've been doing for the longest time.
So you were last talking about patient monitoring as one of the things that is at the forefront, and then off the recorded call, you and I were talking about how there's some other things about how do we get some of these really newfangled technologies at sort of the Apple user level where they're affordable for patients. You had mentioned in the past you had something you were working on. A company gave you a $70,000 per insole thing to monitor pressure monitoring in diabetic.
That's absolutely true. We still have devices like that that are just crazy. I mean, while they're really cool and super fun, just you can really geek out with them, there's just no way they're going to be practical. But that's how things start. They start really expensive. And then there are more and more data evolve to show that they may be useful. Then they start getting mass produced and the price goes down. Example, right now in my pocket, I have an Apple, I got a 12 Pro and the great phone, like usual with iOS. But what's cool, no one knows about here is this camera is a LiDAR camera, a laser. So this LiDAR camera used to cost, just 5-6 years ago, these LiDAR cameras would cost tens of thousands of dollars. Now they're being baked in to iPad Pros and the higher end iPhones. And they're super great measurement tools. And by the way, they're just as good measurement tools as anything else we have in our lab. But I just gave that as an example of things that used to be crazy expensive that are now not so expensive. But on the remote patient monitoring thing, there are any number of technologies now that I'm very excited about. I think there are a lot of data already on products like, there's a smart bath mat, there are smart socks, smart insoles already where there are billing codes through what's called RPM, or remote patient monitoring, where the doc, he or she, can be reimbursed now for monitoring these patients. And that, in fact, we've at our place I've got Rancho Los Amigos right behind me, but at Rancho is one of our sites, and our facilities at USC and at Salsa, but also at Keck, at one of our flagship facility. We've been working on that, and it appears like it's a real thing. I mean, this is something now that we can really bill for by talking about, the data that we're getting back, monitoring these patients. One other thing that we're doing, I'll tell you, it's sort of a remote patient monitoring thing. We call it a foot selfie, and we're having patients just, one of my fellows has designed one of my medical student, third-year medical student, Mark Swerdlow, actually designed a really cool little platform that people can just put their foot on in a free app, and they just say yes when they want to take a photo, and it takes a really consistent photo each time, and it sends it into a protected file. And every Monday at 7 a.m, I review with our students, or medical students, and also some of the podiatric medical students, some of the others, like we can get 50 folks done in like 10 minutes. It's
man, I think
it's called foot selfie rounds.
Yeah.
But I'm telling you that we can teach now. So one of my friends, Moyhun Yap, is working with Oracle on this grand challenge to be able to do that without a human in 10 seconds. And that's kind of it's called the Diabetic Foot Grand Challenge. We're doing it kind of manually, but we can do it really fast. We can say, oh yeah, look at that. It's just a little redness. Every week we do that. We spot, not a week goes by. I'm not exaggerating when I say not a week goes by where we do not identify someone where we mitigate a hospitalization, or where we get someone into clinic and we can mitigate more of a problem, or we see a wound before it's about to happen. It's so awesome. It's so easy. And that's almost free. Now that's different. I don't know that you can I think you can get reimbursed now on that too with telephone stuff. And we certainly try that at our institution, where we're, I think billing for that. And you have all the wizards in our business department that are working on that. But that seems to be something that's also pretty sustainable, to overuse the term.
I know that they do have extra time now as a component they're adding for 21. But what struck me about what you just said is that is a great way to keep engagement with the patient, so that they're partnering. I think that was the biggest study that I saw in compliance, is that the partnership with the patient has to be forged to ensure compliance.
Ben, exactly. We always tell our patients we want to be doing something with you and not to you. And I know that sounds like shit belongs on a poster, but I think people know that, you mean it. You're not dialing it in when you tell them that. And this does bring people in. And you're going to say, well, these folks are self-selecting. The people that would use this, but in fact, and that's partially true for sure.
Sure.
But we are using it on folks that you would not imagine would normally be embracing this kind of thing, right? And it really does draw people in. And all these different tools do it a little bit differently. We're also starting. It's so cool. We're starting this NIH study very shortly. So excited about it. Which has a removable cast boot, really good removable cast boot, but one with smarts in it. And we're trying to coax people into being a little more adherent, like on a smartwatch or a smartphone, but it's going to give them a little happy and a sad face when they're adhering or not adhering to offloading, and kind of ping them a little bit to have a little bit better kind of health economy, just like they might have a little bit better fuel economy if they were in a car that was pinging them like that way.
David, how many hours of sleep do you get a night on average?
Well, you know, you know what, man, I do okay. I don't know. I get a few here and there.
You are the Energizer Bunny. I mean, it's great that you're so focused, because I know, and coffee helps, or tea or whatever. But you know, that's what one of the things though I've been working on is actually getting more sleep, because I find that you know, you get that zone where, you know, you're watching reruns of Breaking Bad or whatever, and
Yep.
then the next day you're not productive, or even that night you can't be productive because you're in passive mode. But you're
right.
doing great, and it's great to see that you're still so involved with and able to keep sort of keep above water with all the things that you're involved with. And I hope that if I'm still doing this gig in another year, then in a year from now, I can have you come back and you can tell me the progress of the studies you're working on.
Oh, that'd be so great, Ben Pearl. Man, this is just, it's great to see you for real.
I'm going to send you the YouTube recording, and thanks again for participating. Thank you, David.
Here's to a happy Turkey Day.
You too. Bye-bye.
Take care, man. Be well. This is great.